Hey, Renew.
Hello, Declan. How are you today?
I'm very well. Nice to be back in studio with some studio guests.
Back in studio, and it's a bit crowded, but in a good way. We've got some fantastic guests today.
We really do. So welcome to this episode of GUcast. This one is supported by our silver partners, Novartis, which is very appropriate for today's topic of future gazing in radioligand therapy for prostate cancer, don't you reckon?
And I have a feeling we're going to get a little bit of a history lesson too.
We are. So that's the idea today. We've got a couple of very eminent experts in the field of radioligand therapy in prostate cancer. We have Professor Michael Hofman, Professor Oliver Sartor, we'll get to in a moment. But the idea is to, well, let's reflect a little bit, but we want to pick their brains and see, what is the future? Where are we going with this extremely exciting area of radioligand therapy?
It's just such a rapidly evolving field, isn't it? From the days of therapy and vision, we've just come such a long way. So it's fun to future gaze a little bit and see what's possible, and maybe look back on this podcast in a few years' time and go, we predicted it then. And
look, we know a lot of our audience know a bit about things like therapy and vision, these trials, and these are the PIs of both of these trials we have sitting here in the GUcast studio. So Michael Hofman, friend of the podcast, our nuclear medicine colleague at Peter Mac, chair of our PSMA Imaging Theranostic Centre. Welcome back into the studio. Good to see you, Michael.
Thank you, Renew and Declan.
And Professor Oliver Sartor, visiting from the US. Oliver, eminent GU medical oncologist, prostate cancer expert extraordinaire from Tulane, New Orleans, and in Mayo Clinic more recently. Welcome, and thanks so much for dropping in.
Well, thank you. A lot warmer here than it was in Rochester, Minnesota.
It sure is at this time of the year. But so you're down here in Australia for a couple of weeks, I think. Oliver, enjoying some time down here. And you popped into Peter Mac this morning into our MDT, our tumour board meeting, and delivered a grand rounds lecture and had a tour of the PET imaging and theranostics facilities. And now out to GUcast, and we'll have some entertainment later in the day.
Absolutely. Beautiful facility and great people, great work.
Great. Fantastic. So that's the idea, Renew, but we thought we would go back, didn't we? And it's kind of, 10 years into PSMA theranostics, so in our experience here in Melbourne. So we were going to ask Michael a little bit to take us back.
Yeah, because a lot of people just know about lutetium PSMA, but there's a lot of other things that came before it that were very good at treatment of prostate cancer, at palliation of symptoms. So it'd be nice to get a little snapshot.
Well, maybe before we go back and ask Michael take us back to the start of lutetium PSMA, which is 10 years in our experience this year. Oliver, you were telling us before in your grand rounds lecture at Peter Mac this morning that you have a very, very long history of radioligand experience in prostate cancer. Why don't you take us back a little bit?
Well, actually remember rather precisely 1993. Okay, 1993.
Wow.
And I was sitting down at a meeting and ended up with a guy named Bill Geckler. And Bill Geckler may not be recognizable here, but Bill Geckler was one of the patent holders for samarium-153 EDTMP. And I was struggling at the National Cancer Institute trying to do something innovative in prostate cancer. And I must admit, was not doing particularly well. We're working hard, but not having much to show for it. And Bill was saying, I can take that isotope and I can put it right on the bony metastatic lesion and radiate it. And I just sort of looked at him and I said, well, how can you possibly do that? And he explained that it would actually bind sort of this phosphonic acid. It's like a bone scan, but therapy. I said, wow, that's going to work. And that was my beginning, 1993.
Wow. What were you doing in 1993, Renew?
I don't know. School.
High school, exactly. I was a little bit
studying
further on, but university for me, high school for you. So that's it. That's the history of it. I recall, in urology learning, there was no role for, barely molecular imaging in nuclear medicine when we were coming through urology. Bone scan was about it, and so on. But Michael, take us back. Take us back to the start of prostate cancer for you with PSMA imaging, but especially the theranostic side of things, I suppose.
Yeah, it's been an incredible journey in the last decade, but it started a little bit before, a little bit after Oliver. I've probably been doing nuclear medicine for 20 years now, and 10 years in prostate cancer, but really transitioned from a lot of neuroendocrine tumour theranostics and just amazed with gallium-68 dotatate PET and lutetium dotatate PET and the impact that had on patients' lives, improving their quality of lives with neuroendocrine tumours, and did that in really high volumes. There's a huge neuroendocrine tumour service at Peter Mac. I think in 1 year I saw 550 patients with neuroendocrine tumours. These are rare tumours, but when you see them in high volumes, you kind of get good at them pretty quickly. And then it was at a EA&M meeting in Birmingham in 2010 that I first saw PSMA, I think in one of the translational sessions, a very sciencey, and it just looked to me very much like dotatate. And back then I was a little bit geeky and I took notes from the meeting and I wrote, because I've still got my notes, I can pull them back, and I wrote, this is a game-changing molecule. I can just see it. So I went back and was like, I'm going to do PSMA imaging and therapy. And it took a few years. I think we did our first PSMA PETs a few years after that, and lutetium. And there were lots of skeptics because we had a choline program, and choline produced a little bit blurry images. They weren't fantastic. They were hard to read. And Declan, what was it like when we doing choline images and I came to tell you that we've got this new test? It's better than choline. It's called PSMA PET. What did you say?
Well, I remember that. I came to Peter Mac in 2010, so around the time you were in Birmingham, like 15 years ago. A small cancer centre. We're growing a big prostate cancer program, and the Nuke Med people, Rod Hicks and Michael, tormenting me a bit, saying, we've got a choline PET program running. I said, I don't think that's much good in prostate cancer, and we can do it every second Tuesday. It's got a half-life of 20 minutes. It comes out of the cyclotron. Sometimes it works, sometimes it doesn't. And, so we recruited patients. I can't remember the trial, but it was very underwhelming. And then Renew, they turn up and say, we got this new one now. The new PET. I said, the PET guys are coming back, annoying me at lunchtime again. And I remember sitting with you two and opening a laptop, and you said, we've just done a PSMA PET CT. It was 2014. Here are the images. And it was like jaw-dropping, that is the primary, and there's lymph nodes and there's a bone met, and I think patient lined up for a prostatectomy. Incredible images, incredible tumor, and that was the start of it. I went, and I said, I presume it's very difficult. You'll do it every second week in the afternoons out of the cyclotron. It'll be very unreliable and impractical. They said, no, this is gallium labeled. It's very straightforward. And I think you had colleagues from Heidelberg, from Germany, visiting or on sabbatical, which kind of helped drive that very fast from when they'd published the initial experience.
Yes.
And likewise onto the lutetium, which and regular listeners will know, Renew, we talk a lot about this. We're not going to deep delve into every trial. We want to go future gazing. But I suppose if you remind us then about how you went from PSMA imaging in 2014 to PSMA theranostics in 2015, 10 years ago, maybe that'll kickstart us before we ask about.
I guess all these molecules, we make them in our radiopharmacies. We have that capability on site at Peter Mac, which is fantastic. And the platform's very similar to what you need for neuroendocrine tumours. So we could give these peptides to our chemists and pharmacists, and off they go and make it. And it's very easy. This is kind of click chemistry for both lutetium and gallium. So it's not overly challenging to make. Choline's actually much, much harder to make. So we made a couple clever decisions. One was we dumped the choline program overnight. We said, we're just going to switch across. This is obviously better. Other places persisted with choline for some period of time. And the other clever thing we did was I decided we're going to do this all as part of prospective trials. We don't want too much, let's just treat patients. So every patient that we treated was done as a phase 1/2 protocol, which was subsequently published. And the easier pathway would have just been to follow our neuroendocrine strategy, which was compassionate access, essentially. Yes, you failed treatments. We've got this treatment for you. That was being done in Germany already. We could see the data. It was compelling. So we did everything on prospective protocols. We did the pro-PSMA trial together, which was a lot of fun, and we just generated some incredible data. And that, I think, contributed to the global science to really take commercial interest. I think I presented lutetium PSMA at ESMO in 2017. I don't know if you were there. I was a little bit of an unknown at that time, just this nuclear medicine physician in this audience of over 2,000 people, predominantly medical oncologists. I was quite nervous, and I gave this talk of the first 30 patients that we treated. And I would say most of the audience had never heard of lutetium PSMA. And maybe, I don't know if you remember that talk.
I was in the room.
Yes.
And to say that you were unknown is a little bit of an understatement. Nobody had a clue. All of a sudden it was like, we're looking at PET image. We're looking at PSMA PET selective therapy. It's lutetium. What is lutetium? What is that? No, I mean, the room was totally unprepared, but I was prepared. I was listening, and I was very much influenced. It was that dose that we took forward into the VISION trial. So I was in the room when it happened.
Isn't that amazing,
what a
Renu? So
story.
those moments then that lead to, but then he sits there, sets up the VISION trial. We're not going to go into that today, but obviously what we can clearly state is there's a very clear standard of care for men with progressive MCRPC now based on VISION and TheraP, which you were co-PI on, both published in New England Journal and Lancet.
And I think it's worth saying that I remember as a nuclear medicine trainee reading the Alsimca trial of radium-223 and just seeing that high quality data it's the only way to change global practice and make these things available. And that really inspired me. I did a PET CT fellowship at Guy's and St Thomas's, where Declan, you've also worked, and they were producing New England Journal manuscripts on PET and lymphoma. And I was somewhat inspired. Let's just try and produce high quality data so that we can really change global practice.
It's a really great example of trials learning from one another and kind of taking it forward and seeing where the next kind of fork in the road is and figuring out which pathway to go down. And Oliver, what about your story? I mean, VISION kind of maybe started from there, but how did you really get into theranostics trials?
1993, Bill Gackler. Then follow that up with radium. And let's explain theranostics in a little bit of a different way, because we're imaging and treating, but now the imaging is bone scans, and the therapies were either samarium or radium. But with samarium, we got palliation. With radium, we got survival. And that's a big deal. That was a really big deal. And then that morphed in to the PSMA targeted therapies with lutetium, inspired by the Hofman experience and being able to figure out the doses. And he did the first prospective trial. And we tagged along on the dose, but we kind of knew how to do the phase 3. And I was part of the Indocite team at that point, which had the PSMA 617 from a commercial purposes prior to Novartis. And we developed that trial, and of course that turned positive as well. So, it's a history that goes back a long ways, but the real, to me, insight was you can target radiation to the right spot and benefit a patient and do it without a lot of side effects. And that has been such a huge insight that it's, to me, not just the neuroendocrine story, not just the prostate cancer story, but in the future, we're going to future gaze, is about all of oncology. We're going to do this across the board. And it's going to be all sorts of cancers and all sorts of targets. And we're going to change the way oncology is practiced. But it's going to take high quality trials. Thank you, Michael.
So with those approvals, Renu, so you have the MCRPC progressive, it's now in every guideline and it's becoming increasingly funded around the world based on VISION and TheraP. But of course, there's so many ongoing trials in earlier disease settings. And your paper on lutectomy that myself and Michael were involved with, read out in European Urology, that's a big leap forward, and that's not clearly standard of care. It's just a sign that maybe these therapies can come forward. But I suppose we're wondering, where will we see the next kind of approvals? Where will we be able to say, in a place like this, lutetium PSMA is now a standard of care option for this stage of disease? And Oliver's got his hand up.
Know the answer to that.
And patients ask this all the time, don't they? They want to know, well, look, I've got this type, I've read about this, but this is my type of prostate cancer. So we're start of 2025, so that we want to ask that question, where do you see, let's talk lutetium PSMA. We'll talk later in the podcast about other tracers, but where do you think you might see, tick, this is now approved?
Okay, it's actually very simple, because in order to change practice, it takes a phase 3 trial. And the phase 3 trials are as follows. We have the VISION trial, which is post-ARPI and post-taxane. And now we have to delete the taxane and just go post-ARPI with no prior taxane. That trial is called PSMA-4, published in Lancet last year. I presented at ESMO 2023 for the first time, and that's now in front of the FDA right now. That's the next opportunity for approval. Now, Curium has another trial called Eclipse with PSMA-INT. We haven't seen the data yet. It'll probably be presented at ASCO. They'll probably be submitting as well, but we don't know. But the first one is going to be PSMA-4, and it's in the metastatic CRPC pre-chemotherapy space, post-ARPI. Next one is going to be hormone-sensitive prostate cancer, completed accrual in January of 2024, 1,140 patients, metastatic castrate-sensitive prostate cancer, PSMA PET positive, everybody ADT, ARPI, and then they get plus or minus lutetium. And we're going to have to wait and see. We don't know, obviously.
PSMA addition.
PSMA addition trial. Then we have the PSMA DC trial. The PSMA DC trial is PSMA PET positive, conventional imaging negative, SPRT plus or minus the use of lutetium with an MFS endpoint. So the next one's going to be PSMA-4, the next one to report will be PSMA addition, and the next one after that is in phase 3 is going to be the PSMA-DC. PSMA-DC stands for delay castration. But I'm going to predict that within 2 months, we're going to know about PSMA-4 at the FDA, within 2 months.
Fantastic. Let me ask you a question.
Yeah.
Because they are the practice-changing studies. There's no question, and we need those. Without those, it means it's just not available. But then we have our smaller studies like therapy or NZP or upfront PSMA, our little phase 2 cooperative group or physician-sponsored trials, which kind of we've specialised in a little bit. And I like to think that although they're not practice changing on their own, they're very complementary to these phase 3 studies. It optimises how do you sequence it, or it even provides the FDA some confidence that, yes, I can make this decision for the VISION trial, but if I didn't have therapy, maybe they might ask for another trial if that doesn't exist. True? Do we need these other little trials? Are they valuable? Or do we just need the industry phase 3 trials?
No. We absolutely require exploratory trials. And, one of the things you've done, Michael, is to leap far ahead of the game. I mentioned very specifically the VISION trial was your prospective trial that led to the dose and schedule, okay, without a doubt. If we going to look at the upfront, we have the first experience really with the castrate-sensitive trial. It doesn't change practice, but it informs us very valuably. And then as we move forward with the whole variety of trials, and I'm going to pick on the LuPARP study for a second with combination, that paves the way forward for the larger studies. We must have complements. We cannot just do the giant phase 3s because we don't even know what to do. We know what dose to use, what combination to use, and how to pick the patients. So to me, this is all part of a larger ecosystem. And we stir it together and we come out with good things. We have a mix of trials, a mix of investigators, a mix of priorities, a mix of isotopes, a mix of combinations. It's all good because it works together.
Yeah, it makes perfect sense, doesn't it? And hats off to Michael and Shanine, who was there this morning, and other investigators who've done these hard graphs. Louise Emmett, who you're spending time with in Sydney as well this month. But I think I really like that, Renew. I like the idea that our audience want to know, when are we going to see approvals? And I think Oliver just said to us, this is in front of FDA, so that's already one step earlier. Yeah. I suppose, what about the timing of the step into hormone sensitive? So Arun and Michael, Arun Azad, who has led the upfront PSMA trial, presented at ESMO recently, Lancet Oncology, is hormone sensitive, but again, smaller phase 2 trial. And it gives people a little insight into maybe what PSMA addition might show. But what's the timescale for PSMA addition?
Okay, so we completed accrual with 1,140 patients, January 2024. It's reasonable to think that by January 2026, we'll have some pretty good information because that'll be median of 2 years follow-up. Now, we know that the medians with an ADT RP, when it comes to RPFS, are probably going to be out in the 28 to 36 months, and maybe even a little bit longer. Depends on patient selection. But we're going to be having some reasonable information within, I'll say, a year and a half from now, something like that.
RPFS.
RPFS. Yeah. RPFS primary endpoint. It's a crossover.
Next year.
One of the things that's problematic, and I just want to emphasize this for a moment, when you have high rates of crossover, it obviously is going to be treating patients before they hit the OS endpoint, and you're going to be confounding the OS endpoint. And that happened to PSMA-4 because of those who were eligible, 84% crossed over. Yeah. And so it's really hard to hit an OS endpoint when you have such a high rate of crossover.
But of course, we think it's a good thing for a trial, isn't it, to have a crossover, ethically.
It's super exciting. I think earlier use is coming. It's only a matter of when. And I'm confident we're going to move pre-chemo pretty quickly. NZP's got some follow-up just about to read out. And even the upfront PSMA results they're actually way better than I expected. If anything, therapy results were maybe not as good as I expected when we look at OS versus carbazitaxel, but you look at upfront and NZP, and they're both significantly better than I expected.
I'm going to give a little bit of a shout out on NZP, which is reported initially in a combination with enzalutamide. And I think that the impact of the overall survival endpoint, which will be potentially presented fairly soon, is going to be high. And the overall survival attracts attention like no other endpoint can. And I'm just saying, I'm looking forward to ASCO GU. Louise Emmons could be presenting that data. So could be a big impact.
Really exciting. And I think the other advantage of the smaller phase 1-2 trials, Michael, is, it gives a lot of information about tolerability, safe doses. But the other thing we do is we're really tight with patient selection. And that's one key thing that we see in trials. But Oliver, how does that translate into the real life setting? Especially when it comes to lutetium PSMA treatment, how is patient selection kind of regulated?
Oh, tightly, unbelievably tightly. And let me explain if you don't understand how, because if you don't have insurance coverage in the United States, you don't get the drug unless you're on a clinical trial. On a clinical trial, you can do whatever the eligibility criteria is. While the insurance coverage is set in accordance with the FDA label, and the FDA label is set in accordance with the inclusion-exclusion criteria that are established by the pivotal studies done that the FDA uses to approve the drug. That'd be VISION. So take the VISION criteria and take that into the FDA approval and put that in the label, and that's what the insurance companies will do. And they will not do anything else because you can't get reimbursed. And at $42,000 a dose, I don't know anybody who's paying for it themselves. So bottom line is the insurance companies rule the roost, governed by the FDA label, governed in turn by the trials that are pivotal for the approval. Just that simple.
And as we bring, lutetium PSMA forward in the treatment spectrum, I think patient selection then becomes even more important. And I think the great thing about all these smaller trials is that there's this translational component embedded into a lot of these that inform us about how do we better select patients. And it's particularly important when we're using it earlier and earlier in the treatment setting and comparing it towards other standards
We deep
of care.
dived on a case in the MDT today on a patient who had been treated with terbium 161 on our clinical trial. And Oliver looked at the picture, and in a microsecond he was like, what's the SUV mean of that patient? And he wasn't surprised that the patient had a good response when he saw that it was a very high SUV mean. So we do have these prognostic predictive biomarkers, and I think that's going to be a little bit of the art of medicine, is you've got the patient in front of you. There's 5 treatment options: PARP inhibitor, docetaxel, lutetium, awesome combinations. What are you going to choose? And if you've got a very high SUV mean, I'm going to be choosing lutetium. But guess what? If your SUV mean's really low, I might say, you know what, you're going to need lutetium, but I actually think you're going to do better with docetaxel first. And that's what we already kind of do in our practice. If you come to our lutetium theranostics MDT, some of it's all about sequencing. We're not saying you're not going to get this. We're just saying, why don't you use what's likely to have a better response? And everyone wants lutetium. That's the truth, because it's so well tolerated. It's the new drug. But when the patients come to me and I say, look, you're probably going to respond better to chemo, they go back to their oncologists and they ask for chemotherapy. It's quite remarkable.
Well, one of the things that's a little bit interesting is that I'm going to quote Michael in a way that he may not have anticipated. So, translational studies. Let's go to Ed Kwan, and he presented last year at ASCO an immensely important finding on circulating tumor DNA. And simply looking at the circulating tumor DNA fraction could have a predictive effect on the lutetium efficacy. And I didn't think that was going to be true. So while we're looking at molecular imaging, we're probably also going to have to look at circulating tumor DNA in addition to the fitness of the patient and other parameters. But when it comes to best decision-making, it's going to be multidisciplinary, and genetics are going to play a role too. So I told Michael a bit earlier during the conference, I said, they're infants and they're children and they're adolescents and they're adults. And you know what? The truth is we're really in our infancy. We know so little. We've learned a lot, but we're so much more to learn. And we are going to change the world, but we're going to have to learn a lot more in the process. And that learning is how we're going to change the world in the end. So lovely to be here.
Michael, since we're future gazing, surely AI algorithms and AI tools will help us, select patients and predict who's going to respond better?
Surely. Yeah, it's a challenging one, but AI is coming. We all probably use it a little bit in our day-to-day practice. I'm all for getting AI to help me do what I do on multiple levels. SUV mean is probably a pretty good one for a single-click solution for AI to do. That's coming. We're going to need some AI assistance. Some of this needs individual face-to-face patient consultation. There's no way around it. There's a nuance there that humans just do better than AI. And patient preference is very important. What does the patient want? Do they want to live longer, or are they focused on quality of life? Some patients will tell you, I don't care how toxic the treatment is. If I'm going to live longer, give it to me. Other patients will tell you, quality of life is my number one. I don't want side effects. This is really important.
And Oliver, before we move away from lutetium PSMA, I'm interested about treatment combinations.
Me too.
Because, so far we've been really disappointed by prostate cancer in the immune system. And we've seen a lot of this in our lutectomy translational work as well. Where do you think the future is? I mean, if we could combine lutetium PSMA with the ideal thing that would change the immune system, whether it's a vaccine or a CAR T, where do you think the future could lead us?
Wrong question.
Okay.
Sorry. All right, so
we'll edit that bit out.
No, it's a good question because it leads me to I think a more interesting place. So you're focused on the immune system, and I'm focused a little bit larger. So let's talk about combinations just for a brief second. Well, what do you think NZP is? That's combination therapy. Sure. That's combination therapy with the hormones. And guess what? I think it's going to be a lot better than just the monotherapy. So let's consider hormonal therapy. Let's consider immunotherapy, but it doesn't always have to be the PD-1, PD-L1 axis. It doesn't have to be CTLA-4. There's going to be other ways to do it, and I'll come back to that in a second. Let's consider isotopes and isotopes. Michael's doing a trial with radium-223 targeting the bone in combination with lutetium. And guess where a lot of the failures occur? They occur in bone. Maybe we need to treat bone better. Okay, and then I'm not going to mention the liver, but the liver's a problem. Let's imagine we have DNA repair inhibitors. Let's go to Peter Mack, and we're going to talk about Shanine Sandhu presented the data with a LuPARP, which is a really great idea to be able to inhibit the damage repair genes while damaging the DNA. So we're going to damage DNA and inhibit those that repair the damage, and maybe get 1 + 1 is equal to 2.5 or 3. So combinations with hormones and isotopes, and by the way, chemotherapy and radiation sensitizers and DNA repair inhibitors and immunotherapies. I'm not sticking with just immunotherapy. There's more to the story.
Yep.
Now, if allow me one more brief statement. So the immune system can be engaged a lot broader than in the context of PD-1, PD-L1, and CTLA-4. Right now, we have active T-cell engagers. And now we're talking about bispecifics. These are non-radioactive compounds. But we're going to look at the STEAP1 targeted bispecific T-cell engager. And you know what? It's active. And now we have the masking of things like the Janux, where we're going to be masking to diminish the side effects and targeting a T-cell engager. So we can engage the immune system in new and different ways. And that's going to be complementary with the lutetium. It doesn't always have to be exactly at the same time, and it doesn't always have to be on the same target. Anyway, so let's expand our immune system discussion to a bigger platform.
Yeah.
And Renu, the final area we want to go into while we have these two folk here in the audience is about moving away from lutetium and wondering where we're going to be in 5 or 10 years with other radio tracers, other targets. You mentioned STEAP1 already. So, we believe that we're still just at the kind of start of radioligand therapy in prostate cancer, but maybe kidney cancer today, as we talked about. But
Infancy. Remember, you're an
Infancy.
You're not even a child yet. Just an infant.
So, you trialists and pioneers in this area, can you give us a snapshot of where you think we might be, or you'd love to be in 5 or 10 years with little things you're already using maybe, or little snippets of it? Oliver, first, of where we might be in 5 years in our podcasting studio. This is in its infancy. We'll still be going in 5 and 10 years. So,
Yeah.
What are we going to be excited about?
Okay, so combination therapy, absolutely, I'm excited. I don't think we understand dose and schedule yet. I think we can optimize dose and schedule. I think we may be using different isotopes. We have presentations on terbium coming up. Or terbium may be just the ideal cat's meow for a low volume cancer, or maybe it's going to be an alpha. And remember, there's more than one alpha. There's actinium, and there's lead-212, and maybe astatine, and of course, radium's the old one. So we have different isotopes, different combinations, different targets, which we've begun to talk about, but just touching on, different doses and schedules. Come back in 5 years and all this is going to be different. Come back in 10 years, it's going to be totally different. It's going to be so much fun.
That's so good. And on targets, just before we go to Michael on it, so PSMA is what we've been talking about. It's been amazing. And so can you explain just for the layer members of the audience what sort of targets you have in mind? So PSMA is expressed in
Let's talk about what I'm going to now call validated targets. Because if I talk today, I give a big long list of targets. But STEAP1 is a real target. Some of these patients having beautiful responses with a T-cell engager from Amgen. Let's talk about HK2. HK2 has got real responses. I have a patient who's been in almost complete remission for 3 years after targeting with an actinium-based HK2 antibody. Unbelievable response, PSA 400 and beautiful. So HK2, STEAP1, PSMA are all validated. Then we get into all these other things that might emerge among certain differentiated subsets or undifferentiated subsets. Maybe it's going to be a TROP2, maybe it's going to be a DLL3, maybe it's going to be a B7H3. I don't really know. That's why we need to explore. But targets today, PSMA, absolutely positively. HK2, I believe it's real. STEAP1, it's real. And that's the beginning, not the end.
Amazing. Michael, we'll throw it to
Very
you.
good.
Tracers, targets, what gets you excited? What trials would you love to do? And what tracers are you excited about?
Well, I've given a little thesis on this in a few talks at nuclear medicine meetings where I'm kind of asked to do a longer talk on this. Maybe we can link to one of those, but it reminds me of an editorial I wrote for J&M about a year ago, which we titled The Hierarchy of SUVs. And I very much a believer that we need to get dose to tumour. And if we can do that, we'll have successful theranostics and we can image and see it and quantify it. It's not that useful when you're in a big phase 3 trial. You don't need all of that. But to start with, to know, is this going to work or not? That's very useful. And we're still in the era of palliative theranostics with lutetium PSMA. And I think the future is going to be hopefully curative theranostics, where we give a big dose of radiation and we actually cure patients, eradicate them, no more cancer. And this is not pie in the sky, because the best theranostic we have to date is radioactive iodine for thyroid cancer, being used for over 80 years. You take a patient with metastatic thyroid cancer, lung, bone metastases, and with a single dose of radioactive iodine, they can be cured. And we've been doing this for over 80 years, and it's truly remarkable. And we can image iodine. And when we do that, we see SUVs, so SUV being standardized uptake value. When we now image with a PET version of iodine, I124, we can see SUVs over 2,000, which is incredible. And, that's not new. That's 80-year-old theranostics. PSMA, a high SUV max we're talking, would be 100, 150, maybe 300 is the maximum. You get radioactive iodine often over 2,000. That's not even unusual. It's frequent. So it's not surprising that radioactive iodine is a curative theranostic. So I think with the advances that we have now in radiochemistry, there's been incredible paradigm change in our ability to make peptides of all different descriptions, mini bodies, even antibodies. I'm less excited about antibodies, but small fragments. I think we need slightly smaller molecules for theranostics, but the radiochemistry is unbelievable now. And we've got a whole new library of traces to play with, from actinium to lead-212 to terbium to astatine. There are so many. So when we combine these new traces with new targets, I think we're going to have curative theranostics. Maybe early phase prostate cancer we can cure.
Lutetium
Maybe we're going to put the urologists out of business.
Bye-bye.
I do
we have the podcast. It's all right.
I do actually believe that you could cure patients with a lutectomy type approach, but it's going to be a minority of patients. They're the patients, when you image them with PSMA, you see a super high SUV. We saw this in pro-PSMA. There was an edge of the bell curve. There were some patients that had SUVs over 80 in their prostate primary. Now, I would love to treat those patients with a neoadjuvant lutetium approach, and maybe with the right isotope, you could cure those patients with a single dose of radiopeptide.
Wow. Hey, that's very inspirational stuff. But Saul Hertz would have been proud. Michael delivered the Saul Hertz lecture at the SNMMI last year, their keynote lecture, and the godfather of theranostics.
And you have his pen.
But it's very interesting, isn't it, to hear that, Oliver? Yeah. So it's cure. You can cure cancers with radioligand therapy. It's tracers and targets and bang. When you find something that has an SUV max of 2,000 in the prostate, there you go. You're going to have focal therapy with
pretty amazing. But you know, we might be able to do it with some of these combinations as well. Because I'll give the classic example with an oncology. So Hodgkin's disease was considered to be incurable, and then we give one chemotherapy and it would work, and another chemotherapy and it might work, but everybody always came back. And then this crazy guy named Vince DeVita said, I'm going to give one, I'm going to give two, I'm going to give three, I'm going to give four all at the same time. And he had MOP chemotherapy. And all of a sudden, the previously uncurable became curable. And patients with widely disseminated disease went into complete remission and stayed there forever. So I believe not only in the theranostic approach, but also the combination approach. And using these molecules which work differently from a mechanistic perspective to be able to intervene on a tumor which may have several vulnerabilities that when combined become lethal, could be pretty cool.
There you go. What a great way to finish an inspirational podcast about the future gazing in radioligand therapy. And patients
very exciting field.
Cure, you're using the word cure in patients who we don't talk to that about, or minimizing morbidity compared to traditional treatments. It is exciting ideas ahead. Yeah?
Absolutely. I've learned a lot.
Great. I very much enjoyed that. So great to have had Oliver and Michael Hofman.
The gurus of theranostics.
Absolute gurus here in the audience with us, picking their brains. And I hope that you all enjoyed that. Thanks very much again to Novartis, our silver partners, for supporting GUcast so we can put on this sort of thing. And we're going to go and enjoy a bit of lunch with these two now, pick their brains a bit more and see where we can go.
Sounds good.
Fantastic.
See you next time.
Thanks very much. Take care.